Hello, PsychU US and Australian communities, and welcome to today's webinar, Perspectives on International Guidelines for Depression. This is our first international PsychU event, so we are thrilled to step into the global arena with all of you. Thank you for joining us. I'm Rachel Self, Senior Medical Science Liaison for Otsuka Neuroscience Medical Affairs. I'm joined today by my colleague, Dr. Mel Noke, Medical Science Liaison for Otsuka, Australia. We will serve as the moderators for today's discussion, featuring Drs. Jen Mahli, Roger McIntyre, and Sagar Parikh. Without further ado, let's go ahead and kick this exciting panel off with our first question. And I will actually direct this one to Jen, if that's okay. Why are clinical guidelines needed in psychiatry? What's the purpose that they serve? And how do they help clinicians in our everyday practice? So we'll start with some heavy-hitting questions here. Jen?
Thank you, Rachel, and welcome everybody. It's a pleasure to be here. The CADE clinic is named after John Cade, who rediscovered lithium and its utility in bipolar disorders. And so we see complex patients with mood disorders. And really, that's where guidelines come in. Guidelines have to drive our decision-making. And we've recently published the Royal Australian New Zealand College Guidelines in the ANZJP in the January issue of this year. And the accompanying editorial asks precisely the question you've asked, which is, why do we need guidelines? Why are they still necessary? And I think we just have to look at COVID, for example, last year, why we needed so much guidance over some very simple matters. We've known for ages, based on germ theory, that infections are transmitted through not washing and through airborne transmission, for example. And yet people needed reminded time and time again to wash their hands and cover their faces, and not to transmit bugs, as it were. And so guidelines are needed, even in very basic sort of medicine, rather than more complicated scenarios that we have in psychiatry. Now, our guidelines are more complicated. We're dealing with people, we're dealing with complex psychiatric disorders, but I would argue that really their guidance is even more important because it drives the decision-making both for the clinician, but also gives an understanding to patients. So I think the purpose they serve is a synthesis of the evidence, firstly, and provide a template for clinicians to refer to, on top of which they can still exercise judgment and make decisions.
Thank you. We'll just go in alphabetical order. Roger, did you have anything additional?
Well, first of all, great to be with you all for this discussion, and this international discussion. It's so appropriate that we're having an international discussion discussing such a condition, that being mood disorders, major depression, and bipolar disorder, which certainly knows no national boundary. It's certainly an international burden right across this, this globe. No, I think that Jen really has hit the highlights. And for me, the way I think about the need for clinical practice guidelines in our area of depression and bipolar disorder really, I think, is really instantiated by the heterogeneity, not only of the patients and the types of populations that we service, but also the heterogeneity of the treatments. We have many different types of treatments within classes, for example, within pharmacology, but even non-pharmacologic approaches are also quite different. And it certainly is the case that as we really work with patients and families towards the fundamental goal of giving them their lives back, it's important that they have care providers who are informed by the best available evidence, but also making choices that reflect the best knowledge we have around safety, cost effectiveness, and really those treatments that are accessible and available in their local jurisdictions. And CPG's clinical practice guidelines across chronic diseases have, in fact, unequivocally shown to improve health outcomes, very broadly defined, and in some cases, cost outcomes, and probably most importantly, from the patient's perspective, patient-reported outcomes. So I see guidelines as reducing the entropy, the chaos of what we do, providing more clarity, and certainly providing more structure.
Thank you. Sagar, anything to add?
Well, thank you for the opportunity to participate in this discussion. My learned colleagues have certainly covered some of the more important areas of why we have guidelines, but I'd like to add a couple of practical things. This is an era of information overload. And just as we saw all the kinds of rumors or allegations that various treatments would help with COVID, so it is throughout depression or throughout psychiatric illnesses. There are many different sources of information and authority, and both the clinician and the patient suffer from information overload. We need some curation of that information. We need to be able to manage all of these different facts and interpret it. If we're going to have informed decision making either by the patient or by the clinician, they need some assistance in the practical translation of what may be a massive number of studies. So what guidelines do is they help the clinician sort out what are the key facts, what are the most important facts, but also they help the patient. The patient is, of course, at a disadvantage, not having gone through medical school. It's that much harder to be able to select treatments. And if there are guidelines that synthesize this, particularly guidelines which incorporate patient and family values, then that really makes the job of clinical care that much easier for the patient as well.
So I was going to add to that, Sagar. I agree. And I think what you're really alluding to there is authority. The fact that guidelines provide some recognition that these have been developed through careful consideration, drawing the evidence together, and provide something as a reference for both clinicians and patients to turn to. And it's a starting point often for a conversation around what is available, what is recommended. And I think that's a really important point. I also take your point about information overload. I think that we've always had a lot of information. I think the accessibility to it and the availability has increased. And misinformation in particular is the big problem, that there are a lot of people who through websites and other means are putting out information that's not necessarily accurate. And so we have to counter that with guidelines as well.
Yeah, I like, Sagar, your point about the information, the too much information, TMI, and I agree with you. I've often said we don't need more information. What we need is more actionable information. And what guidelines do is they reduce the chaos, the entropy of what's out there. And they provide a scaffolding, and they provide what I think is much more actionable. They take the extant literature, synthesize it through the process of peer review and expert opinion, taking the evidence-based guidelines through systematic reviews and so on, and say, okay, here's what's there. Let's take this information to the cusp of action. So I think guidelines really, in fact, as I said, reduce the chaos and take a world of too much information and bring it towards more actionable information. For the busy practitioner, that's what they want. They want that type of actionable information.
I think we needed to hear that as a society. It's not just individuals and clinicians.
Yeah, good point.